Hi, I'm Jennifer Horn, and I'm a registered nurse and a senior certified specialist of poison information at the Blue Ridge Poison Center at UVA Health System. And today I'm going to be talking to you about the nursing toxicological assessment. So, in order to cover our objectives, the first thing that I would like to say is I'm hoping to provide a head to toe assessment of the toxicological patient to you and provide some clues to help point you in the direction of potential poisonings based upon your nursing assessment. And then lastly, to enhance the communication between you as the nurse caring for the patient and the healthcare providers, as well as relaying specific information to the poison center when we call for follow-up. The first thing that I would like to cover is history. The history is so important to help give us some information as to what's going on with the patient, but it at times can be difficult to obtain. But it's important to get as much information as you can in regards to the history of exposure. And some people who can be beneficial to that are family members, friends of the patient, EMS providers, or police who maybe arrived on scene of the exposure, things of that nature. Unfortunately, a high number of patients are often unreliable in giving details of their own ingestion. Sometimes history of exposure can change frequently. Some examples that would be helpful in these types of situations are suicide notes, evidence that's found at the scene, such as empty pill bottles, or other victims may have suffered the same exposure and are presenting with similar symptoms, such as a carbon monoxide poisoning. In some cases, patients are unable to give information about the exposure due to deteriorating clinical status, such as CNS depression, altered mental status, auditory or visual hallucinations, or on the other end of the spectrum, children who are just simply too young in order to accurately give a report of what's happened. Time of exposure is important. A good example of why that's relevant is in acetaminophen poisonings, because we're going to use that time frame to determine when blood draws need to be obtained, as well as treatment strategies. And then how long was the patient down for? Is this going to be an issue medically later on, such as rhabdomyolysis? And were there any witnesses to the exposure? ABCs. Treat the patient, not the poison, but that's initially. In the beginning, it's important for all toxicological exposure patients to have their ABCs immediately treated and taken care of. We will later on in the conversation talk specifically about the poison. Supportive measures should take top priority in the treatment of a poison patient. Is the patient's airway intact and breathing? What's the patient's blood pressure and heart rate? Are they fast, slow, high, low? Are the cardiac intervals wide? Most poison patients do well on supportive measures alone. But when the ABCs are addressed appropriately, most patients respond to additional therapies and managements better, and/or additional therapies and managements can be pursued. A good example of this is that a patient has to be cardiovascularly stable in order to be placed on dialysis. And if they're not, then we would have to use a measure such as CRRT, which is not as effective at removing toxins as hemodialysis is. Neuro. What is the patient's mentation like? Are they CNS depressed, like they could potentially be from an overdose of anticonvulsants or alcohol? And what's the range? Is it mild, moderate, or severe? Are they stimulated or agitated, like they would potentially be from cocaine or amphetamines, or is it normal? Are they able to have a conversation with you? How about their pupil size? Is it large or small? Large in the presence of a TCA overdose, alcohol, amphetamines, cocaine, or antihistamines, or small or pinpoint in size, such as opioids or clonidine. Is there nystagmus, such as a dilantin overdose or alcohol? Is the patient able to maintain their own respirations? Are they so CNS depressed that they're kind of forgetting to breathe on their own? Are they protecting their airway? How about their body temperature? Is it high or low? Is it high in the presence that it would be potentially for ecstasy overdoses, SSRI overdoses, or salicylate poisoning? Or is it low, such as the presence of CNS depressants? Is there any seizure activity? Is the patient tonic-clonic? Do you happen to see that they're post-ictal after already having a seizure? And some examples of where that could come into play would be either alcohol withdrawal or an overdose of INH. On exam, is there clonus, tremors, or hyperreflexia? You could potentially see these from fluoxetine overdoses, trazodone overdoses, and bupropion. And lastly, is the patient rigid that you could potentially see from an Haldol or a phenothiazine overdose? Cardiovascular. What's the patient's blood pressure and heart rate? Again, I use the high, low, fast, slow situation. Is the blood pressure up, like you would see in cocaine or Benadryl overdoses, or the blood pressure low, like you would see potentially in a TCA or Haldol overdose? Is the heart rate particularly fast, where you could see in a TCA overdose, theophylline, or Benadryl? Or is their heart rate low, like you could potentially see in digoxin, beta blockers, or calcium channel blockers? What does the EKG or cardiac monitor reflect in terms of diagnosis and cardiac intervals? When you first take an initial look, is there a normal sinus rhythm? Do you see PEA, a dysrhythmia, AFib, or VTAC? Is the QRS duration greater than 120 milliseconds? You could potentially see this in the presence of a tricyclic overdose. What's the QTC? Is it greater than 500? You could potentially see that in a methadone or a trazodone overdose. Respiratory. What's the patient's respiratory rate? In this presence of a salicylate overdose, the patient can have a particularly high respiratory rate. In the presence of an opiate overdose or a benzo overdose, the patient may have a low or slow respiratory rate. Is there cyanosis? That could be indicative of a patient that has been down for a prolonged period of time, or it could give you a clue that the patient may have been exposed to nitrates in water or benzocaine that is inducing a methemoglobinemia. Does the patient have secretions or pulmonary edema? You can see something like this in the presence of an opiate or an organophosphate exposure. Is there evidence of an aspiration or cough? If there's aspiration, has the patient vomited? That could help be a clue for you in that setting. Or has the child swallowed gasoline or baby oil and they're effectively coughing? GI and GU. Does the patient have abdominal pain? An example where you could potentially see this would be an exposure to NSAIDs. Or is it more specifically right upper quadrant abdominal pain that you could potentially see from an acetaminophen overdose? Is there nausea, vomiting, or diarrhea? Some examples that you could potentially see these symptoms are NSAID overdoses, acetaminophen, salicylate, organophosphate exposure, or mushroom ingestions. Is the patient anuric or having urinary retention, like you could potentially see from a Benadryl overdose? Or are they polyuric, like you could potentially see from an exposure to diuretics? Is the patient incontinent of stool or urine? That could be a clue for you that this patient may have been down for a while, or have they had an exposure to organophosphates that make it so that they can't control their urination and defecation? Does the patient have decreased bowel sounds? A good example of when you could potentially see this is from a Benadryl overdose or some other anticholinergic toxin that slows the gut motility. Extremities and skin. Is the patient sweating or extremely dry? If they're sweating, this could clue you in to the potential for cocaine or organophosphate exposure. But if they're extremely dry, that could be a Benadryl or tricyclic antidepressant. Do you see needle marks on your exam, which would give you a clue that this patient suffers from IV drug abuse? Is there evidence of skin breakdown? This could help tell you that the patient was down for a prolonged period of time and could potentially lead to rhabdomyolysis. Are there burns, first through third degree, or any blisters? This could give you the clue that a chemical exposure has been involved in some way. Or is there a puncture wound, swelling, or pain that you could potentially see from a snake bite, insect bite, or some other animal bite? Laboratory values. Labs requested will be specific to the patient's exposure and potentially the patient's daily medication list. The minimum labs requested for intentional overdoses that you're going to hear us request when we call to initially give recommendations on a patient or for follow-up are an acetaminophen level, a salicylate level, a comprehensive metabolic profile, and a medication drug level if the patient overdosed on that particular medication or if it's in their daily medication list. Some examples of that would include Depakote, lithium, digoxin, theophylline, etc. Additionally, a CPK may be requested if the patient was found down for an unknown amount of time. It may also be requested if the patient is agitated, combative, or has had an exposure to a stimulant such as cocaine. Again, the concern here is for rhabdomyolysis. A lactic acid may be requested if the patient takes metformin daily and/or has had an intentional overdose of metformin. An ammonia level may be requested if the patient takes Depakote daily and/or has had an intentional overdose of Depakote. Coags and CBC may be requested for snake bites, except for when we know that the known exposure is a black snake. And an ABG may be requested for a carboxyhemoglobin level when there has been a carbon monoxide exposure. So in summary, I hope to utilize a systemic approach to identify toxicological findings and therefore help you to communicate those findings to the interdisciplinary team as well as the Poison Center when we call for follow-up on this patient. Thank you very much.